This is the first CBU of July. We have been running it for the past 6 months, and we have been very fortunate this evening to have Mr. Shabi Ahmed, who is a consultant urologist in Sandsville, Birmingham. I think the same place as Mr. Sami, right, Shabi?
That's correct. Yes.
Yeah. So he's a graduate of Dow Medical College, like most of us. He did his FRCS in 2005 and subsequently his FRCS Urology. He has a great interest in minimally invasive surgery and as well as female urology, which includes major interest in urolithiasis and stone. And this is what he's going to talk about this evening. So floor is yours, Mr. Shabi Ahmed.
Thank you. Thank you very much. Let me see. Thank you very much, Dr. Hamad, for your kind invitation as well as introduction. My name is Shabi Ahmed, and I'm a urology consultant in Birmingham. I'm based in the City and Sandville hospitals. And one of my subspecialty interests is definitely stone disease, along with some minimally invasive cancer work, which I tend to do, which I'll talk about as we go along. And along with that, my other introduction is with regards to medical management and the issues and representation of the Pakistani doctors in the UK. I'm the sitting Secretary General of the Association of Pakistani Physicians Apne in United Kingdom and North Europe. So this is my introduction. In terms of my work, I don't want to say what a urologist does. We look after the whole genitourinary tract from the kidneys down through the ureters, bladder, prostate, and so on. Different people do different works. People have got their subspecialty interests, as well as some people do upper tract, some people do lower tract, some people do benign work, some do cancer work. So it things are very varied in terms of the types of work which we do. Gone are those days when everyone used to do everything, but what subdivisions have done is that it has definitely improved the quality of care, and it has given more experience in hands of people who do one or two different types of areas with much more emphasis on quality and in terms of the work they tend to do in terms of the specialty. What I'm going to do today is I'm not going to talk too much about the recent guidelines on how to manage cancers on or how to do an operation, be it a stone operation or a prostate operation or a kidney operation. My talk is more based towards the concepts of healthcare management dynamics, whether it is health economics, which includes reducing the length of hospital stay, early return to work for the patients so that they are made useful for themselves, for their families, for the community, less morbidity in terms of the operative work we do. And of course, when it's less morbidity, that would imply that there is less blood loss and early functional recovery. So these are the concepts I'm going to talk more about. And what I would like you to understand and think, especially all the trainees who are joining us, that whenever you are in this position where you have to make a decision of what to do or what kind of procedure or treatment you have to offer to the patients, please think of these 6 points which I've mentioned, the healthcare management dynamics or the concepts. I will talk about how the technology has improved our outcomes in the last 10 years and plus. And you may not have all the facilities which I may be talking about at this moment, but life is very dynamic, and what we thought we would never have achieved in the last 5 years, it's readily available now. So the take home message as we go along would be to understand the concept, and when the time comes, when the opportunity comes, see how you can make a difference in terms of implementing these concepts. And when I talk about all sorts of technologies, you can see that the invention of the ureterorenoscopes, be it the semi-rigid scopes, the rigid scopes, as well as the flexible scopes, have revolutionized the management of stone care. The endoscopic management has revolutionized the management of transurethral procedures. But what I would emphasize is this topic, the holmium laser. And although this picture only depicts the holmium laser enucleation of the prostate, it is holmium laser itself which has revolutionized the whole concept of urology management in the 21st century. And what was started as a low powered laser purely for stone diseases has now taken up in terms of soft tissue management. With when we started doing holmium laser prostate enucleations, but now we are doing en bloc resection of bladder tumors. We are doing stricture disease with the laser, not to mention all sorts of stones, including PCNs. I mean, in my personal practice in the last 4 years, I have only used holmium laser as the mode of technology, or as the power source to for stone fragmentation and stone removal. So this by far is the revolution of the 21st century when it comes to urology management. And mind you, 80% of the urology pathologies that we see are benign, are non cancers. So, a huge majority or vast volume of our practice is non cancer related. However, as I go along, I'll tell you that even the holmium has got a role in cancer care management as well. The other whole cousin for holmium is the tholium. So, tholium is something which is evolving at the moment. It has got it is a similar type of lasers, albeit a bit lesser penetrative depth in it, but uh, is a bit more expensive. This machine, which is not available in the United Kingdom but is rapidly taking its place in Europe, has got both the holmium and tholium devices in one machine. As and when it is available to us, it will definitely help us. And mind you, the advantage of tholium is that because the tissue penetration is lesser than the holmium, it is much more effective in soft tissue treatment rather than stones and things in which holmium has got a better role. So when I speak about the minimally invasive components of our treatment for, I'll start with the kidneys really, and how the technology has helped improve the outcomes of kidney disease management. And gone were the days when the only operation people used to do for kidneys was a nephrectomy. Now, even nephrectomy has evolved a lot with partial nephrectomies and with the robot coming in doing robotic partial nephrectomies. Then I will talk about the minimally invasive laser ablation of upper tract TCCs. And then there is a small component of percutaneous ablative techniques, which I've mentioned here. I might not be able to talk too much about it today. So, what the small renal masses, the T1s, the T1As, this is by far it's a very uh, topical discussion whenever whether it's an exam setting, whether it's a discussion in the multidisciplinary oncology meeting or a tumor board. What to do with these small renal masses? Now, unfortunately, there is no perfect answer for these small renal masses. So, what the factors that one needs to be aware of in the management of these small renal masses is: number one, whether it is benign or whether it is cancerous, and it is very difficult to uh, ascertain on the basis of just imaging whether it is definitely cancerous or benign. uh, Whether we need to do a biopsy on it, and it was a myth once upon a time that doing a biopsy on a potentially malignant mass might have issues with tumor seeding or tract seeding and things. However, recent data over the last 10 years or so has shown that it is a very accurate, effective, and a very safe technique. And there is hardly any case reports or anything mentioned about a tumor seeding through the tracts. And even those reports are very debatable. Now, as in when you do establish whether a disease is malignant, whether a partial nephrectomy is doable or not, but then again there are very various factors, patient factors, tumor factors, and so on. So with the advent of the robot and the wide use of it, whether open partial nephrectomy is a thing of the past, that is again a debatable thing. In my personal view, I think there is still a role for open partial nephrectomies in bigger central tumors, but in experienced hands. So small renal masses is a debate that will keep going on. And mind you, with so many scans happening for no particular reasons, but done by the surgeons or whomsoever, we will continue to find more and more of these small renal masses. So for the trainees, it is very important to understand the dynamics of it. And mind you, one thing I would like to mention is that even if you leave the small masses alone just for the sake of observation, the size of growth of that is very, very slow. And that there was a paper from Mayo a few years ago, which said that the growth rate was 0.14 uh, millimeter per year, or something very, very slow. So that's again an argument to make whether we really need to do anything about these small renal masses. To the small renal masses, one thing I would emphasize is that although it is not very accurate to say whether the mass is benign or malignant on the basis of imaging, at least you should get a triple phase CT scan to have some reliable understanding of whether there is a neoplastic process going on or not. Having said that, it is still very, very debatable, and things like AML and other small benign tumors can behave radiologically very much like a cancerous tumor. The problem arises when you have cystic diseases, and with this very confusing Bosniak classification. And although it says that these Bosniak forces are 80% malignant and so on, doing classifying them on radiology and then managing them on operating them is by far quite a challenging process. The other use of the holmium laser comes with the minimally invasive use of laser to laser ablate these upper tract TCCs. Now, the upper tract TCC or even bladder cancer, we all know is mostly a disease of the elderly. The peak incidence happens in the sixth decade of anyone's life. People who end up having upper tract TCCs might have concomitant bladder cancers, as well as the fact that they have multiple comorbidities, their performance status is low, as well as the fact that they're, they have chronic kidney disease, stage 3, even stage 4 in certain cases. The fact is that looking at this small little growths which you can see, or these little polyps, these are mm, low grade or intermediate grade disease. And if somebody ends up having a nephroureterectomy for this small mass, 1 or 2 centimeter papillary lesion, which even at the end with the biopsy comes back as a TAG1 or TAG2, is it really feasible for that elderly patient who is already got multiple other issues to lose their kidney for the sake of just a small tumor like this? The teaching or the guideline still says that the nephroureterectomy is the gold standard treatment for upper tract TCC. However, that does not take into account the patient factors. So, if you have the technique available, I would strongly recommend to laser ablate these tumors and maybe repeat this procedure every 4 to 6 months and keep and the nephron spared. Nephron sparing surgery is something which is very close to my heart and something which would personally recommend. I do run a center in the West Midlands and have a radius of about 100 miles in which people do refer these upper tract TCCs to me for laser management for them, purely on the basis that nephroureterectomy by far would not be in the best interest of the patients. They might not be fit enough to have a major undertaking like that. However, they can still have a short GA or a procedure under spinal or epidural anesthesia every 4 to 6 months, and I can just put my ureteroscopes in and laser ablate whatever little water recurrence is. What it does is that will give them the extra 3, 4, 5 years, whatever their life expectancy would be. But most importantly, that will preserve their quality of life. So please be mindful of the fact that if you have the availability, if you see there are patients who you might think might not be feasible to have nephroureterectomy, elderly patients, multiple comorbidities, please do consider them to have laser ablation of these these upper tract tumors, be it in the ureter, be it in the kidney, and try to you know give them the best quality of care. Next slide, please. So as I mentioned, protecting the nephrons is the aim in all this process. If you save these patients from keeping from losing their kidneys, I'm sure you've done a good job. Next slide, please. Just a few technical points about holmium laser ablation for these upper tract TCCs. Yes, it will need multiple GAs every 4 to 6 months, as I said. The results are better if you have a high powered laser machine, in which at least a 50 watt, if not a 100-watt machine, that will give you better results. If you put a stent up after the procedure and then treat them with intravesical BCG, if it's a high grade tumor, or a mitomycin with low grade tumor, what the stent does is that allows the chemical to reflux back into the upper tracts. Although there is the scientific basis of that is not very well established, it does help in terms of disease control after you've done the laser ablation. The settings for the laser is high power and low frequency, which would be more effective for these laser ablations. Next slide, please. So this is just an algorithm for management of small renal masses, examination history, imaging, and then discussion in the multidisciplinary meeting to look into the patient factors, look into the tumor factors, and then advise what is appropriate for the patient. If it's a young, fit patient with a life expectancy of 30, 40 years ahead of them, then partial nephrectomy by far still remains a gold standard. However, if there is a 70, 80-year old with multiple comorbidities, a 3 centimeter enhancing mass likely to be an RCC, what will you achieve by doing a partial nephrectomy on him? On the patient, they will end up in the hospital for weeks and months, and if their cardiac issues and things will dominate their recovery, and they might end up becoming bed bound. So you've not done a good job by just doing an operation. You have taken away the quality of their life. So consider ablative techniques or even active surveillance in these kind of patients, because what training does is that this is what I was taught once upon a time, that training doesn't teach you just to operate. Teaching and training teaches you when not to operate. So be mindful of these facts, and patient factors would be very, very important in terms of when you decide when and what to offer to your patients. Next slide, please. A few points about bladder preservation. Again, if you control the bladder disease, the bladder transitional cell carcinomas, it is very important that you do a good TURBT. And a good TURBT would be greatly helped if you have got the adjuncts like PDD, the photodynamic diagnosis, which unfortunately is a very costly affair. but at least the narrow band imaging would be very helpful. All you need to do is have a stack system in which you switch on a device, a button, and you see narrow band imaging, and the fluorescence gives you the idea where the tumor is, which you might not be available to be seen on the simple white light cystoscopy. So if you control the disease in in its primary place, that is in the bladder, by doing a good TURBT, then again that will keep the patient, help preserve the bladder, especially in terms of high non-muscle invasive high grade disease. Next slide, please. Similar points as I mentioned earlier in terms of low performance status, mm, kidney dysfunction, elderly patients. So bladder protection is the aim. These patients will never be a candidate for a radical cystectomy, and they will significantly suffer if is an operation that they are made to undergo. So therefore, if you can preserve them, their bladders, try to do that with the use of the technology and by doing a good TRBT, as well as using things like thermotherapy, which I'll just talk about. Next slide, please. Now, another use of the laser is, and this is something which we are still learning, or that is not uniformly available in UK as well, but people are doing it, is resection of the bladder tumor using holmium. The advantage of that is, as I mentioned in the earlier slides, in terms of whether it's holmium or tholium, the tissue penetration of these lasers is low. Therefore, the risk of perforation of the bladder is very low. And if you have a elderly patient, especially females who've got very thin bladders, and if you end up doing a TURBT, there is a very high risk that you end up perforating the bladder, or that ends up with the seeding of the tumor outside the bladder, then that is a nightmare situation. So this, watch out the space for laser resection, which, I mean, I'm sure there are lots of techniques available in terms of en bloc resections and solitary tumors. So this is something which would develop in times to come. It will be more time consuming than the standard resection of the tumor. However, for this better sake of the patient, for preserving their bladder, for reducing the risk of perforation, this again would be something worth considering in future management of these bladder cancer patients. Next slide, please. Little talk about the prostates again. Next slide, please. The one of the biggest changes that has come in the oncological management of prostate cancer, and prostate cancer, as everyone knows, is the most common cancer in the urology world. It is the second most common cancer in men, only after the lung cancers, and but still a much more of a deadlier disease in terms of metastatic spread and problems related to it. What the robot has done, and the current data in UK suggests that 100% of the radical prostatectomies now are all robotic. We had a proportion of about 5% of laparoscopic procedures till about 3 years ago, and that has all been replaced by robotic techniques. But the advantage of robot is that it has changed the dynamics of patient care spectacularly. Patients used to stay in the hospital from anything between 5 and 15 days. They used to have long issues with ileus. Pretty much everyone ended up having blood transfusions, complications related to bowel issues, chest infections, so on and so forth. That is all a thing of the past. Even with the elderly patients, people in their 70s and all with comorbidities and stuff, they have what we call it as a 23-hour stay, which is a new code which we tend to use here, which gives the hospital better remuneration in terms of the tariffs which you get from the primary care. The patient pretty much everyone goes home the next day after a robotic radical prostatectomy with a catheter, and they come back after 5 to 7 days and have the catheter taken out by our specialist nurses. Blood loss is very rare. The current data in UK and as well as in further northern hemisphere countries say that the risk of transfusion after radical prostatectomy is less than 2%. Uh, Patients are able to return to work early. There is hardly any much issues in terms of ileus or issues like incisional hernias and things. And although the data is a bit immature at this moment of time, there is a big hope that in 5 to 10 years' time, when the functional data comes out of these patients who have had robotic prostatectomies, that they will have much better rates of incontinence and erectile dysfunction, or should I say, their incontinence rates or erectile dysfunction rates would be much lesser after these robotic procedures, especially these uh, nerve sparing surgeries and so on. Next slide, please. Coming back to our benign work, which again is our mm, bre- daily bread and butter surgeries. HOLEP is very, very quickly taking over the dynamics of what we used to do as transurethral resection of prostate. Now, transurethral resection of prostate will continue in its role for small and medium sized prostates, but for larger prostates, more than 80 grams or 100 grams plus, in which once upon a time we used to do an open prostatectomy or Millen's procedures. And I tell you, in UK, I don't think there has been any Millen's procedures done in the 5 years or even probably more. So therefore, this is what I would advocate to say that uh, especially the trainees, wherever you get the opportunity and the availability, HOLEB is something that should be learned, and the people should know how to do it. It's an evolving trait, and but going forward, this will be something which will be very important. And the advantage of HOLEB, even with 100 gram prostate, is that most of these patients will go home the same day and come back in the morning and have their catheters taken out. Some brave surgeons might take the catheter out in the evening before sending them home as well. So, again, the fact that patient outcomes would be great with them. Early return to work, 3 to 5 days, um, functional capacities, well, we can debate on that, but they will be more beneficial for themselves. The people who are self-employed, the people who are daily wagers and things like that, they can start earning their livelihood again. They will not be reliant on other means for to feed their families. And this is the best we can do with the use of the technology to give them a better outcome, a better patient outcome. Next slide, please. Again, as I said, bipolar resection is mostly what we are doing at this moment. Hardly ever we do a glycine resection anymore in UK. So advantage is that we are still doing 70, 80 gram prostates with good benefits. TUR syndrome again is hardly ever a recognition these days. So again, patient safety is paramount, and we are using these technologies to the best of our advantages and giving the best shot to our patients. Next slide, please. A little slide to say that the lasers are being used for optical urethrotomy, so don't need to cut, don't need to make them bleed, don't need to make them have a catheter in for a week, 2 weeks. Do a laser urethrotomy, leave the catheter in overnight, and again the outcomes would be pretty much similar to what you would get from a standard optical urethrotomy. Next slide, please. Stone diseases. Now, as I mentioned earlier, the laser started with the use of the stones, or stones was the principal agent that was reliant on the holmium laser. In UK, the recent survey from the British Urology Society says that All the elective stone work is using laser as the only modality of energy source for stone fragmentation. So the use of the lithoclast and things are in the past. They've adopted new things like a, the newer generation of lithoclast, but again that is something which is still picking up. It's not readily available here and there, but anyone or everyone who's got a laser is doing all sort of stone surgery with the laser, be it doing the ureteroscopies or PCNL. Next slide, please. So in terms of PCNLs, now there has been again a radical change in the management of percutaneous stone surgery, even for big stones. And now, I mean, I can tell you in my personal practice, I'm doing all the PCNLs as supine, all the PCNLs as tubeless, in which I've in the last 5 years or so I've not left any nephrostomies in more than 100 cases I've done. And it was a myth when we started doing mini PCNLs that it is only for smaller size stones, for solitary stones. In my series, which I'm going to present later this year in the endourology meeting, we have done stones up to 6.5 centimeter with the mini PCNL in single sitting. And all we did was leave a stent in, and the patient went home next day. The rate of discharges after 1 day or 23-hour stay, as we call it here, is more than 95%. And one or two patients who stayed beyond that were more to do with social reasons and so on. Therefore, again, a point to mention is that, and again, this would be very debatable whether to say that the standard PCNLs or the prone PCNLs are things of the past or not. If not now, but surely in the times to come, in the next few years, they will be uh, sentenced to the urology museums. So mini PCNLs is the effective way forward for the management of percutaneous stones, big volume stones. Advantages of doing it supine is that it is much more physiologically comfortable. Your anesthetist would be very happy rather than putting it prone. It will be very helpful that these patients will not have any problems with their respirations and their chest issues, which is an issue when they are prone. So again, my suggestion, my request would be for all the stone surgeons to try to do as many procedures of percutaneous nephrolithotomy, the PCNLs, in this supine position. And please do not put in nephrostomies, because there is no added advantage of a nephrostomy. It is a very painful exercise. The patients are in a lot of discomfort with a big fat tube coming out from their back, and it does not give any much drainage advantage as otherwise a stent would do. So please try to change the way of post-operative drainage of the kidneys after stone surgery. One quick and last point I would do mention is that the percutaneous punctures for these stones, we do all our punctures with ultrasound guidance, and which helps us to identify the vascular anatomy as well. So the AV malformation, the AV fistulas, which used to be a problem once upon a time, hardly ever we've seen anything in the last 10 years. None of, in my hands, I've never had any issues with an AV fistula. None of my patients had bleeding to the point that they needed embolization and so on. So again, with the use of the technology, I think these are more myths. Things have moved on, and these complications are pretty much a thing of the past. Next slide, please. So this is what I did 5 years ago when I joined, when I started mini PCNLs in Birmingham. At that time, my senior colleagues were doing PCNLs. Their patients were having nephrostomies, prone PCNLs. They used to stay in the hospital for at least 5 days. And after cutting through the red tape and having a lot of problem, you know, cutting out the problems and the myths of the management of the nursing staff. We started to do these mini PCNLs and started sending the patients home the next day with the senior ward matron really having a go at me and starting shouting that why are you sending a PCNL home next day? I said, don't worry, they will be fine. And touch wood, no, none of them ever came back with any complication. So therefore, we've established the technique in the last 4 to 5 years. We've done more than 100 cases very effectively. We're doing huge volume of big stones, as I say, 6-7 centimeters stone burden, big complete stag horns, single sitting. Just leave a stent in the end, and patients are extremely happy. So technology has helped us. It has changed the paradigm of the management of benign as well as cancerous cases. Next slide, please. And to conclude, I would say that all these tools are still a tool. They need a lot of training. They need a lot of due diligence in terms of to decide who to offer what kind of modalities. And only with all the experience and the confidence which you have in your own selves, in your ability as a surgeon, then you will be able to deliver these modalities and then make a difference for the patient. So if you have a big laser machine, don't think that you can do anything with it unless and until you know how to use it properly, you know what to offer to your patient, and only then you would be able to make a big difference. Next slide, please. So to conclude, in the purely speaking, in my last 10 years in urology, things have radically changed. Things which we were taught to do as a trainee, we hardly do anymore. We were taught to do open radical prostatectomies. Nobody does that anymore. Used to do prone big PCNLs. We hardly do that anymore. Our ureteroscopies used to stay in 2, 3 days, sometimes 4 days. Hardly ever does that happen. So technology has helped us a lot, and all for the benefit of the patients. So if they go home, if they have less pain, they don't need transfusion, they don't have ileus, they have got good functional recovery, they are back to work within a week. I think we have done a good job. So please take home these messages. And as I said earlier, you might not have all the modalities and all the technology at your disposal at this moment of time, but life is evolving very rapidly, and definitely you will have all, if not most of these things available in the next 5 years or so by the time you are in your practice. So whenever you have the opportunity to make a decision what would be in the best interest of your patient, please think how you can make a difference so that your patient will suffer less. Thank you very much, and I'm happy to take questions.
Thank you very much, Mr. Ahmed. Very comprehensively covered some of the developments that have taken place in the last nearly one and a half decades in urology, and a significant number of things that you have mentioned are being actively practiced in most parts of Pakistan as well. There is a question from Dr. Shafiq Mehman. Shafiq Saab, can you open the mic for Mr. Professor Shafiqur Rahman, Sharif? Shafiq Saab, unmute yourself and please proceed.
Excellent talk, Mr. Shabi Ahmed. Actually, this is the need of the time, and you very elaborately discuss all the latest endourological modalities. There are many questions coming into mind, but at least I thought to ask from you about urethrotomy, laser urethrotomy. I recently started doing the laser urethrotomy also, and I have a holmium laser 80 watt. My settings are the frequency is 10 hertz and the 1 joule is the energy. So what do you think? And the next other thing is that at did you give the incision same at 12 o'clock or you modify anything?
Yeah, thank you, Shafiq Saab. It's a pleasure to have you on board. Uh, the technique is pretty much similar. You put a guide wire in, you do the incision at 12 o'clock, exactly what you used to do with the cold knife. The settings would be for soft tissue is high power, low frequency. So I would suggest that you can have energy up to 2 joules, a little more, 2.5 joules with frequency not more than 10 or 12 at the most. So that is what my recommendation would be.
Yeah, I mean, the high energy and low frequency is a setting for soft tissue, and I think you can adjust it accordingly if there is a lot more fibrosis. And also depends upon the laser machine that you have. So if you have a
Absolutely.
100-watt laser, you probably cannot go beyond 2 joules in that. I mean, it really doesn't matter too much, but majority who do laser, rather than doing the 12 o'clock incisions, they generally do a circumferential widening of the lumen, in which you go around, keep increasing the diameter of the urethral lumen. But I think it's more or less the same, works the same way.
In
So
the
do you do?
recent bouts, there was a paper in which one of the French surgeons was doing like a tri-radiate or tripod incision. So incision at 12 o'clock and 5 and 7 o'clock, something like that. But again, these are anecdotal cases in which people have their own techniques. The idea is to treat the stricture, where you incise and how you incise. Even when we used to do the cold knife optical urethrotomies, in some certain cases, it was not possible to do it at 12 o'clock for whatever technical reason. So you used to make the space wherever it was feasible to do it. So in surgery is a very, very volatile area. You have to make the best of it in terms of the space and the availability.
Absolutely.
Uh, 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 Dr. Hamad Attar and Mr. Shabi. The thing is that I recently saw a video from a Kalkrani group. Mr. Pankaj Joshi was actually shared the video in which he advocate giving the incision with cold knife at 6 o'clock because he believed that all the fibrosis is around the corpus spongiosum, and he said that you turn the scope and give the 6 o'clock incision. I don't know whether you have seen that video or not, but what is your opinion regarding that manual?
Yeah, as I said, these are anecdotal techniques of one or the other surgeons. They have their own ways of doing things, but my personal, I've not seen a 6 o'clock incision. But again, it all depends on personal preferences, what people are safe in doing, and what is effective and for the patient and safe for the patient. So uh, at the moment, the standard technique still remains what we were taught years ago. However, the laser is evolving, but using the same techniques and the same measures as we used to do for the standard optical urethrotomy.
Thank you.
So any other questions that any of the audience have? Okay, you can post your question in the chat box or raise your hand and we will open up the mic. Right.
I would encourage trainees to be free to ask questions, be bold and ask questions, even if you think that the questions might be very trivial or very simple. But please have the confidence to come and ask these questions, because this will help you a lot uh, in terms of your overall outlook as a surgeon. Anything you want to ask, please feel to ask.
Okay. So if there are no further questions, I think we still have 10 minutes. And if it is okay, I'll share a brief talk on thulium fiber laser, which Mr. Shabi Ahmed also briefly mentioned. This is a new innovation in the laser field. I was fortunate enough to give this talk recently in the experts in stone disease meeting in Athens. So I think I'll just use that 10 minutes. Is that okay with you, Shabi?
Okay, that's okay.
Great.
Fantastic.
I mean, I was trained to do laser ablations on upper tract TCCs in Barcelona, and over there they use tholmium rather than holmium for this technique. So I don't have the tholmium, but if I would have it, tholmium for soft tissue is very, very effective. I think you're mute, Dr. Ahmad.
Yeah, I mean, thulium fiber laser is very similar in soft tissue, maybe a little bit more effective than holmium. But this thulium fiber laser for urolithiasis is a relatively new thing. So maybe just a 7, 8, 10 minutes talk on this, and then we can discuss a little further.
Sure.
Of urology, not only for soft tissue, but also for urolithiasis. And to our experience, it has been a wonderful gadget that the urologists have, and they're able to do a lot more than what they used to do with pneumatic lithotripsy and ultrasonic lithotripsy devices. We know that holmium YAG laser is a pulse laser. It's a solid state pulse laser. It's in the invisible spectrum. It's infrared with a wavelength of over 2100. The quartz crystal of holmium YAG are excited by the flash lamp. It is strongly absorbed by water. The thermal injury zone is 0.5 to 1 millimeter, so that provides a safety zone. It works essentially by photothermal as well as thermochemical mechanisms. And the photothermal results in laser energy absorption, chemical decomposition, and ablation of stones. And the thermochemical mechanism essentially works by vaporization of water inside the stones. And as a consequence, what happens that the stone bursts from inside. So essentially a combination of these two, and it has been working well. And with the recent introduction of the MOSIS technology, we were able to cut down the retropulsion significantly as well, which is important both in the ureter and the kidneys. Well, the new entrant in the block is thermal fiber laser. It is also in the infrared spectrum with a wavelength of 1940, and that's what most of the studies have been on, although there is a wide range of wavelength for thulium. The optical penetration depth is about 4 times shorter than holmium YAG. So it would work closer and it would not have significant impact beyond 1 millimeter. And it has 4 times lower stone ablation thresholds. So essentially, it is a more powerful laser with pulse frequencies of up to 2200 hertz and very low to very high pulse energy. So it can be as low as 0.05 to 6 joules. It is a very long pulse duration, so it essentially provides more of a continuous sort of laser with 200 microseconds and up to 12 milliseconds. Total power of up to 55 watts, which is more than enough for urolithiasis. The stone ablation efficiency is 4 times as much. So when we had such a wonderful laser, why we needed another one? And is it going to be the current gold standard, which is essentially holmium yak? However, holmium yak is a huge machine. It's a heavy machine. It's built in such a way that it produces a significant amount of sound as well because of the water cooling system. And in comparison, the thulium is a much smaller unit, is 1/8 the size. It is only 30 kilograms. The Olympus Optima, Saltive actually, and it can be plugged to a wall socket. So it doesn't require specific electrical connections. So is thulium going to become the new gold standard? Well, with peak power of 500 watt, it emits very small pulse energies of 0.025 joules, which again is as important, and I'll show you how. Going up to 6 joules, so you can use it for fragmentation as well, with a frequency of 200 hertz. So it all translates into the thulium fiber laser ablates twice as fast in fragmentation and 4 times as fast for dusting. This gives it a much higher ablation efficiency, and it produces a much finer quality of dust, which would flush out rather easily, rather than leaving 0.2 mm fragments, which sometimes become very irritating, and you find the CT scan post-operatively, even at 1 month, showing some small fragments, and that's to the dismay of our patients who are really not happy with seeing those small stone fragments. Another added advantage is that it reduces stone retropulsion. So if you look at the machine specification, one can appreciate that rather than the flashlight excitation of the quartz, there is electronically controlled laser diode providing constant peak power of up to 500 watts. The same pulse energy range as any high power laser like holmium, which is 0.2 to 0.26 joules, but for a 120 watt laser, and then very low pulse energy as well, which is 0.025 joules. So it's really quite low to 0.1 joules. It has very low pulse energies. So that's again a big advantage. Pulse frequencies of up to 2400 hertz, very long pulse duration of up to 50 milliseconds. And the machine itself is several times smaller. It uses quite air cooling mechanism rather than water cooling mechanism, which takes all that sound away from the operating rooms that we are so used to now. There is a reduced energy consumption, so again an added advantage, and it can be, as I've said, plugged to a wall socket. One of the concerns that were raised in the initially when the thulium laser was introduced is about the thermal effects of thulium fiber laser. The thulium's high absorption coefficient in water equals high temperature. That was the observation. The heat production of 1 joule of TFL energy is 4 times that of holmium yak laser. So essentially, the initial authors believe that this may translate into a much higher temperature rise of the fluid around the stone in the collecting system and in the ureter, which can be to the detriment of particularly in the ureter and can result in strictures. However, subsequent experiments and studies have shown that it is not correct, and there is no amplified temperature with the use of thulium fiber laser. And the thermal safety precautions are used. So it is as similar to the holmium yak laser. However, for high power settings, without appropriate irrigation, dangerous temperature rise are observed. And it's important that we are cognizant of this fact. So if we're using high power settings, we need to be really be good with our irrigation, and particularly using cooler irrigation fluid to keep the temperature within limits. The thulium laser fiber are smaller. So the smallest fiber with holmium is essentially 200 microns. So we have much smaller fibers with, and the smaller fiber means that they can provide and they leave some space in the working channel of the ureteroscope, which will allow some irrigation fluid to go through as well. They're more flexible, and the flexibility is extremely important because even with the 200 micron fiber, it is not possible to bend your scope, particularly in difficult angles, particularly in the lower pole calyx, to be able to fragment stone in that location. So you sometimes have to relocate your stones to pelvis or upper pole calyx in order to do fragmentation, because there's significant bending effect on the scope, which can actually damage the scope as well. Its resistance to bending has another added advantage, that the microfractures, which can lead to firing of laser within these scopes and can cause micro damages to the inside of the scope, are also avoided because it can bend without fracture, without any leak of the laser energy. Additionally, there is less burn back, and this obviously would improve the life of the laser fiber. Now, if you look at the laser fiber, which of TFL as well, and holmium YAG, the smaller fiber presents several advantages. I've said better scope deflection and accessibility, more irrigation and better visibility, less retropulsion. And if the scopes are miniaturized in future, I think TFL would be the laser of choice rather than holmium YAG, unless the holmium YAG laser fiber can be reduced further. So, well, all these properties, the important thing is that stone ablation efficiency is increased because of this. So the fragmentation is twice as faster than holmium YAG. Dust are 4 to 5 times as faster than holmium YAG. So which translates into shorter operating time, produce finer dust quality, which can flush out rather easily. The dust and the residual fragments are much smaller than that of the holmium YAG. Additionally, there is reduced retropulsion and sometimes absolutely no retropulsion in the ex vivo studies that we have had access to so far. So clinically significant retropulsion at 1 joules, whereas the same thing can happen with 0.2 joules of holmium YAG. So 5 times better in terms of retropulsion than the holmium YAG laser. The other important quality, although they are both very well absorbed in water, holmium and thulium, at 0 millimeter, 100%, whereas if you move to 0.3 millimeter away, then the holmium YAG efficiency decreases by 37%, whereas that of the thulium fiber laser is only decreased by 1.7%. However, if you move 1 millimeter away, then there is still significant laser energy, which is reduced to 4%. However, it's almost no laser effect at 1 millimeter. So that adds to the safety profile of laser as well as decreased retropulsion. Well, availability is an issue. And if we look at the market at the moment, Russia was the first place where thulium fiber laser was experimented and approved. There was some initial, all the initial studies also came from Russia. FDA approval was obtained in 2019, whereas the CE mark was approved in 2020. However, thulium fiber laser is still a rarity in most urological departments, even in the United States, Europe, and more so in the developing world, except India, where it is available to the best of my knowledge. So what about this new kid on the block, acceptability in the developing world? Well, since there is paucity of studies and there are few RCTs, the ratification of excellent preclinical findings are there. They have to be ratified by these clinical studies. So more RCTs with head-to-head comparisons with the current gold standard, which is HOYAC, is required. Although there is an advantage that it's lightweight and easy transportation, which is, I think, important from the perspective of developing countries where you'd really need to move your laser machine from one place to another. However, there are issues with capital cost and maintenance, which needs to be looked into. So essentially, if you have a new technology and the new technology is cost effective, and it has clinical effectiveness as well. Well, if the clinical effectiveness is low and it is cost effective, then it can be discarded. However, if the new technology is, the cost of new technology is less or low, and I think thulium fiber laser probably is, effectiveness of new technology is more, then it should be adopted immediately. So I see a future of thulium laser in the developing world as well. And it's all because of all the properties that we have talked about, and probably with the cost factors taken into consideration, I see a promising future for thulium laser. Thank you very much for your attention. So this is something that, again, I think, I don't know, Shabi, if it is available in UK. Do you know people using thulium fiber laser in UK at this moment?
Yes, thulium is picking up quite fast in UK. The only issue is that most of the centers have invested quite heavily in the holmium in the last 3 to 5 years. So getting a financial approval for a new laser in a space of 3 years after spending about 2.5 to 300,000 pounds for high-powered laser is something which our management frowns upon. So having said that, this is not the end of it. As I said, technology is evolving very rapidly, and I'm sure we will have some technical and clinical means to justify the use of tholium as times come. So I think it's just something that we just have to watch the space, and things will evolve in times to come. A few of my colleagues I know, and even in the West Midlands, have got tholium, but they were lucky enough to get the new machine as a donation by certain philanthropic societies and stuff. So there are things that will be available in times to come.
Yeah, thank you. Yeah, I think the potential of this laser for developing world is significant because it's likely to be much cheaper than the holmium yak. And the advantage, and let me just tell you the real life situation in our part of the world. What really happens, except for some of the bigger hospitals, majority of the smaller public sector hospital, private sector hospitals, their laser is provided on a loan basis by the company. And they move the laser machine from one unit to another whenever you use it, need it. You can, because it's difficult for most hospital, and it's okay, even for a rich country like UK, there are problems in acquiring these expensive gadgets. So the advantage of this machine is likely to be because 90% of our work is stone. And it's a small unit. It's only 38 kilograms, and it can be moved from one place to another rather. So if the effectiveness is proven as the preclinical data is indicated, and with the lesser cost, probably if you're planning to buy another laser machine for stones, thulium fiber could be a strong candidate.
I think one of the other factors would be the disposables. If the laser fiber for thulium is cheaper, then of course this will merit much more attention as compared to the fiber for the thulium. You'll be surprised that in the whole private sector in the United Kingdom, none of the hospitals own a laser machine, and all these laser machines are provided by uh, third-party providers who own these machines. So if we have to do a private case in stone case in the private sector, so we just have to notify the hospital, and they ask these providers to bring their machines in with the technician, and they provide the machines. So uh, things are not as smooth as one would like it to be, but that's life.
Yeah. So I think we've just exceeded time, but I think it was a very wonderful discussion. And thank you very much, Shabir, for providing a very comprehensive review about minimally invasive surgery, particularly for our junior colleagues who are starting off a practice or thinking in terms of using minimally invasive surgery into their practice. And you'll be happy to note that things have changed significantly in most parts of Pakistan, where minimally invasive urology is the dominant theme. And sometimes we can talk about open surgery role in stone, which is almost gone. So you hardly ever hear about an open pyelolithotomy or even ureterolithotomy. I think you provided a wonderful background of the way our modern generation urologists should be practicing. So I'm really grateful to all the audience for sticking around and listening to this wonderful talk from Mr. Shabi Ahmed. And I hope to engage him again sometime in the future. And thank you very much and have a very good evening.
Thank you very much. It's been a pleasure to be here.
Thank you.
Thank you.